In the operating room, ending a surgical procedure requires a precise transition. We move from deep skeletal muscle paralysis back to spontaneous respiration. At the tissue level, down at the ulnar nerve and the adductor pollicis muscle, this requires restoring chemical communication across the neuromuscular junction. Throughout the surgery, non-depolarizing neuromuscular blocking agents like rocuronium, vecuronium, or atracurium maintain a flaccid paralysis. Reversing this state safely and predictably is a strict clinical requirement. The primary pharmacological tool for this is neostigmine, a carbamate cholinesterase inhibitor. Neostigmine operates indirectly as a carbamate inhibitor rather than a direct receptor antagonist, and its efficacy is bounded by a strict mathematical ceiling effect at the molecular level. Success requires mastering its receptor dynamics, respecting its absolute timing roles, and neutralizing systemic collateral damage. Treating neostigmine as a simple antidote leads to premature distration. This miscalculation leaves the patient with postoperative residual paralysis, triggering hypoventilation, airway obstruction, and lethal extubation failure. To understand neostigmine's limits, look at how paralysis is maintained. Presynaptic vesicles release acetylcholine, crossing the synaptic cleft and binding to postsynaptic nicotinic receptors. Non-depolarizing blocking agents induce flaccid paralysis by acting as competitive antagonists at these exact postsynaptic sites. They occupy the receptor channels, preventing membrane depolarization and muscle contraction. These drugs also operate through a second, parallel mechanism, antagonizing presynaptic alpha-3 beta-2 nicotinic autoreceptors. In a normal state, these autoreceptors facilitate a positive feedback loop that mobilizes acetylcholine vesicles for rapid release. When blocking agents bind to these presynaptic receptors, they disrupt this positive feedback. If the motor neuron is subjected to rapid successive stimulation, the terminal cannot mobilize enough vesicles, progressively reducing the amount of acetylcholine available for release. This physical depletion of neurotransmitter vesicles directly causes the clinical phenomenon known as fade. This diagram shows the Trainophore, or TOF, stimulation protocol, delivering 4 rapid electrical stimuli to the ulnar nerve. The first twitch's amplitude correlates to the postsynaptic block. The progressive drop-off in the next 3 twitches represents the presynaptic block, indicating depleted acetylcholine. The physical fade observed on a patient's thumb is the macroscopic translation of presynaptic acetylcholine depletion at the cellular level. This diagram shows neostigmine's mechanism, binding to and inhibiting acetylcholinesterase. By preventing this breakdown, endogenous acetylcholine rapidly accumulates and floods the cleft. This gives acetylcholine the competitive numerical advantage needed to surmount the paralytic agent and reactivate the muscle. This mechanism has a central limitation. There is a finite amount of acetylcholinesterase in the junction. Once neostigmine has inhibited all available enzyme, there is a maximum achievable limit to how much acetylcholine can be pooled. This establishes a rigid pharmacological ceiling effect. Beyond this threshold, administering additional neostigmine has zero clinical benefit. Neostigmine fails during a deep blockade, categorized as a Trainophore count of 0 to 3. At this depth, receptor occupancy by the paralytic agent is too high. Even maximum pooled acetylcholine cannot displace the sheer volume of antagonist molecules. During a shallow blockade, receptor occupancy drops. Pooled acetylcholine wins the competitive race, overwhelming and physically knocking the paralytic molecules out of the receptor channels. Because of this hard mathematical limit, attempting to reverse a deep neuromuscular block with high doses of neostigmine yields a dangerously slow, unpredictable recovery and significantly increases the risk of airway obstruction. Intravenously administered neostigmine circulates systemically, spreading far beyond a target skeletal neuromuscular junction. The resulting inhibition of acetylcholinesterase causes a flood of systemic acetylcholine that indiscriminately activates muscarinic receptors across the entire parasympathetic nervous system. Unopposed, this parasympathomimetic activity carries severe clinical consequences, including profound bradycardia, bronchoconstriction, and massive gastrointestinal hypermotility. To prevent this, neostigmine must always be co-administering with an antimuscarinic, antispasmodic agent. The 2 primary agents used for this are glycopyrrolate and atropine. They competitively block the muscarinic receptors in the heart, lungs, and gut, while leaving the nicotinic receptors of the skeletal muscles unaffected. Glycopyrrolate is routinely preferred because its onset and action closely matches the kinetic profile of neostigmine. Without the protective shield of an anti-muscarinic drug, reversing skeletal paralysis would routinely trigger lethal autonomic collapse. A major exception to this protocol exists for succinylcholine, the only depolarizing neuromuscular blocking agent in common clinical use. This chart illustrates succinylcholine's mechanism: an initial muscle fasciculation followed by a phase 1 depolarizing block. The train of 4 response lacks the fade of non-depolarizing agents. Unlike acetylcholine, succinylcholine relies entirely on plasma butyrylcholinesterase for clearance. This creates a pharmacological trap. Neostigmine acts as a partial inhibitor of this plasma butyrylcholinesterase. Administering neostigmine during a phase 1 succinylcholine block actively prevents the succinylcholine from being broken down in the plasma. Giving neostigmine to speed up succinylcholine recovery will intensify and dangerously prolong the patient's total paralysis. Because of these complex receptor dynamics, the American Society of Anesthesiologists dictates reversal protocols based strictly on quantitative monitoring. This table outlines when reversal agents are safe. For blockades between 0 and 3, neostigmine is ineffective. Use Sagamodex. Neostigmine is delayed until shallow blockade, confirming a count of 4 with fade, or a ratio between 0.4 and 0.9. Relying on subjective visual assessments of muscle twitching is inaccurate and frequently misses dangerous levels of residual weakness. The final safety benchmark for extubation requires waiting a minimum of 10 minutes post-reversal and using a quantitative monitor to confirm a train of 4 ratio greater than or equal to 0.9. At a ratio of 0.9, the vast majority of presynaptic autoreceptors and postsynaptic channels have been successfully cleared of the competitive antagonist. Effective neuromuscular reversal depends on calculating the precise point where the patient's own neurotransmitters become mathematically capable of reclaiming the motor end plate.